Our bi-weekly webinar series highlights research at the University of Pittsburgh School of Medicine. Today's topic is innovations in the management of otitis media. So I know all of you with kids or grandkids are going to appreciate this, or maybe you're dealing with yourself, but there's a lot of, this is a very prevalent issue in throughout the society. So I'm Lawton Snyder, CEO of the Ioneer Foundation. The Ioneer Foundation supports research to advance care for vision, hearing, balance, voice, and cancers of the head and neck at the two world-renowned departments of ophthalmology and otolaryngology at the University of Pittsburgh. Now, the funds we provide to support research are only made possible because of philanthropic support. So I always need to let you know that that's important, certainly to continue to do the kind of work you're going to hear about today. Housekeeping, that chat for today's webinar is disabled, but we want you to use the Q&A function to answer any questions, and you can put those into the Q&A at any time. I'll read those for us and for Dr. Santa Maria at the end of the program, and we'll begin the discussion with you about some of the questions that you have. Refrain, if you will, from asking very specific personal health questions, but if you have personal health questions, you can email them to Mr. Craig Smith, who's the email on your invitation, or you can send them to me as well if you can find my email address. Please feel free to use the subtitles and closed captioning if you need that, and then you will receive you will be added to our email list for future webinars. So let me introduce you to Dr. Santa Maria. Peter Santa Maria, MD, PhD, is a professor and division chief of otology and neurotology here at the University of Pittsburgh. He's the vice chair of translational and clinical research at the Department of Otolaryngology and Head and Neck Surgery in the University of Pittsburgh School of Medicine. He's the director of faculty innovation for the Office of Innovation and Entrepreneurship, so he wears many hats. He's the co-director of our Pittsburgh Creates initiative and co-director of Pitt SPARK and Gorongosa SPARK. And he's an adjunct professor of bioengineering at Carnegie Mellon University. So we're incredibly lucky. Dr. Santa Maria has been here just for a year now, but we're incredibly lucky to have somebody with so many skills applying it to our patients, but also a lot of innovation, which you're going to hear about today as well. So it's my pleasure to introduce Dr. Santa Maria, and looking forward to hearing your presentation today as well.
Thanks, Lonnie. It's my pleasure to talk to everyone as well. It's always fun to talk about something I'm passionate about and very interested about. And as Lonnie alluded to, my clinical practice and my research all involves otitis media. So I just would hoping to give an overview of everything that's going on in our lab and our collaborators to help give people some insight into what's going on. It's also on the background of, as Lordy mentioned, there's a huge faculty here that are all researching hearing conditions. And many of these are in otitis media or otitis media related conditions, or the complications of otitis media, which is inner ear hearing loss. So we're really proud of our clinical and scientific faculty that we have here, looking to bring the standards of otitis media. It goes without saying that we have an incredible history here at Pittsburgh, and literally Dr. Bluestone wrote the book on otitis media. He passed away recently, unfortunately, but there is a huge history here, started with Dr. Bluestone and continued by many other investigators and researchers here at Pittsburgh. And also Dr. Paradise, who's in family medicine, also no longer with us, but also his legacy continues here. He actually, his criteria for tonsillectomy still persist in our guidelines in our specialty society in ENT. But he also did a lot of work around, when and how we should treat otitis media from the family medicine point of view. So really a deep history in Pittsburgh and a current team that are really excelling in this field. So the first thing is I wanted to just clarify what is otitis media. So otitis is inflammation of the ear, and media is of the middle ear. And so when you look at that, just from anatomy, we divide the ear into the outer, middle, and the inner ear. The outer ear is the ear canal, and sound travels into the ear canal. And that's, where you might put an earplug. And then when it hits your eardrum or the tympanic membrane, that's where the middle ear begins. And you have these three bones in the middle ear, the malleus, incus, and the stapes. And that then vibrates or conducts that sound from the eardrum into the inner ear, the cochlea. So that middle ear cavity is the space between the eardrum and the cochlea, the inner ear, and that is a air-filled space, and it needs to vibrate that sound. And that air that gets into the middle ear gets into there from the back of the nose, and that goes up and down through your eustachian tube. So when you swallow, you can hear a slight little click. That's the muscles of the eustachian tubes opening, and that equalizes the air in the back. And that's typically, if you're going to do a Valsalva maneuver by holding your nose and blowing, how you pressurize your ear, that's sending air up into the middle ear. And also that's typically, if you have kids that are crying on the plane as it's descending, that's usually because they're not effectively pressurizing or depressurizing the air in the middle ear, causing pain in the eardrum. So otitis media or chronic otitis media is really what we're looking at here. Acute otitis media is the typical, you have an infection, and you would get that through having an upper respiratory infection that you would then cause some inflammation in the eustachian tube and have some fluid build up in the middle ear. Most of the time that goes away. Sure, it causes some discomfort and fever in children's, but the majority of those get better. But the problem stems from those that become chronic. And this is the spectrum of disease that we kind of look at. So the first condition up in the top left, you can see the eardrum, and behind the eardrum, you can see these bubbles of fluid behind the ear. And this is otitis media with effusion. Sometimes we call it glue ear because that effusion behind the eardrum can become so sticky. The middle is where sometimes when you have an acute otitis media, you have so much pus that's built up in the middle ear that it bursts through the eardrum, and often that eardrum hole then heals, but sometimes it doesn't. And that's when you're left with a tympanic membrane or eardrum perforation. You can see that hole in the eardrum there. Commonly, those eardrum perforations become infected, and that's what we're looking at the bottom right there, where it's an eardrum perforation with a lot of pus that's kind of sitting in the ear, and that's chronic suppurative otitis media. So we're all seeing different spectrums of a similar disease, but they cause slightly different issues for the patient, but they're all major challenges for doctors and parents. So the first condition that I'd like to talk about is otitis media with effusion. So it really is a costly problem and a common problem. So we sort of joke about it. It's kind of it's just part of being a child, or a hazard of being a child is that you're going to get otitis media. And 90% of children before the age of 5 will have an ear infection. And chronic ear infections or having the glue ear is actually very present at 1 in 5 preschoolers at any given time. So it's really common. It's a very expensive problem in the US, at least $5 billion of costs every year. And it's other than wellness visits to your pediatrician, it's the #1 reason why children go to the doctor. And it causes problems. So if it doesn't get better, the biggest problem that we see as physicians and as parents is that you can imagine having a lot of fluid in your ear can impair your hearing. And when kids are young, this is during a critical period of language and brain development. And if it persists for long, it actually can have long-lasting mental effects and speech effects. It can lead to speech delay. And we've actually seen studies where it can actually lower your IQ. So it's horrible to see this, this condition affect the child's development and education in the long term. It can affect certainly the quality of life in the short term. If you're having chronic ear infections, those things can become acutely affected again. So you can have more fever and pain episodes, and overall causing sleep disruption, both to the children and their parents. And it can have, again, a secondary effect on the education and learning of that child. There's a relatively simple solution to that. and that is putting tubes in ears. Ear tubes are when we put a little hole in the eardrum and we put a piece of plastic to bypass the eardrum and allow the fluid to come out of the ear, but also the air to get inside the middle ear. Even though we promote this as a relatively straightforward procedure, and it's up there with the most common procedures in the United States, being done around 700,000 times here, we do see that these are not the simple things that we promote, because 1 in 6 of these need to be reoperated on. My adult patients would know that we're often putting them back in again. 1 in 4 of these will become infected at some point, and sometimes these infections can become difficult to clear. And of course, parents don't want to put their child through anesthesia if they can avoid it. And this is just a quote from one parent saying at the bottom right, saying, it was traumatic for myself to watch him, being my child, being anesthetized, as it was worrying and stressful. And we all would rather not have anesthetics if possible. But once we all say it's easy to do it once you get there, but we all know it's not easy to get appointments with ENTs or otolaryngologists. It can be a long time to be delayed to get appointments, a long time to be in delay to get to a pediatrician before we get there. And we've seen, certainly in the United States, there's going to be 6 to 12-month delay through this whole process. Once you get there, it costs $3,000 on average. There's a copay of $300. And so, there's a large surgical cost associated with this condition. And this is where we're talking about one innovation that we're happy to present here, and this is the earflow. So this was invented between Stanford University and Pittsburgh University clinicians and researchers, and it's an at-home treatment that treats the child's otitis media with effusion through a sippy cup. And what it does is it uses a precisely controlled air pump to unblock the middle ear, and it can be used in young children as low as 1 year of age. And I wanted to talk about how that works. So here a child is holding the sippy cup, and then they will get to drink it. You can see there. And what it does is it has a little mask that's attached to it that's fitted around the nasal cavity there. It forms a seal with the nose whilst the child drinks. It then detects when the child is swallowing, and that swallowing action causes the back of the nose to be sealed off. It then, the device then gives a small gentle puff of air into the nasal cavity, which then travels up the eustachian tube to assist in opening the eustachian tube and then removing the fluid from the middle ear. By removing that fluid from the middle ear, we can then restore hearing to the children, which is similar to what we would do as a procedure if we make a hole in the eardrum and suck out the fluid directly. Here we're doing it through a non-invasive way by allowing the child to drink. So it's really cool that we're able to you can see there the child is playing a game with that, and the child can be motivated in doing the right pressure by getting the rocket up and hitting the stars. This child is actually an expert at this. You can see it goes green at the bottom of the device every time it works, and he's incentivized to do the treatments every day to collect his stars. So really excitingly, there's a publication that was published recently in our Academy's journal of our first study based on 21 children. What we did is we sat the research team up at a clinician's office, and these children had failed observation, and they were referred to this doctor for consideration of having tubes put in. The research team took the children aside, got them to use the earflow device, and sent them back to the doctor. And interestingly and incredibly, 84% of those children had improvement or resolution of the fluid in their middle ears in at least one ear. And many of these children went along to not have recommendations for surgery. We then had a second study that is going for publication soon, where we tested a further 18 children, and we allowed them to take the device home. So we wanted to see if the result could be sustained or changed when the device was being used. So the children had it at home for 4 weeks, and then we let them stop using it for 4 weeks before they had assessment again by our ENT. And what we found was that 78% of the children that had hearing loss had resolution of their hearing loss, and 80% had some form of a success during that study. So we were really excited with those results. And the good news there is that it's going through FDA approval later this year and should be available on the market by winter. So that's a really exciting device that could potentially remove or reduce the need for having tube surgery in children for a big problem, one of our common conditions while we put in tubes, otitis media with effusion. So the other exciting development here is eardrums perforation. So just in the middle there, you can see an example of a hole in the eardrum. You can imagine if you have a hole in the eardrum, it doesn't conduct very well, and so you have some hearing loss just associated with the hole. It's these come in all shapes and sizes, and it can cause all sorts of hearing loss just from having that hole. This is what we typically do to repair a hole in the eardrum, and it's a procedure called a tympanoplasty. And we're just going to look at some pictures that explain how that's done. So on the top left, you can see there's an illustration of an eardrum with almost a kidney-shaped hole, which is one of the larger perforations that we see. What we usually do is we do this under anesthesia, and we use an instrument to excise the margin of that hole, and that really allows the edges of the hole to become freshened. It allows a lot of blood and other acute inflammatory factors to get in there to help with healing. Once we do that, we lift up the eardrum. You can see there, fold up the eardrum, and then we take a piece of tissue from another part of the body. One of the common places that I take it from is just the front of your ear. We call it the tragus, that little cartilage piece in front of your ear. And then we insert this as an underlay. We kind of slide it in there. We use a couple of different techniques to allow that graft to knit into the eardrum. We replace the flat back. You can see there at the bottom right. And that takes about 6 to 8 weeks to totally heal before we think that it's all healed. So it's a relatively straightforward procedure, but it requires a little bit of manipulation. It requires a surgery for the patient and a general anesthetic. So one thing that we're really proud of, and you can see down the bottom, there's a solution, is that we invented a topical growth factor that could be injected onto an eardrum of a patient in the clinic. This is really exciting because it came from my own PhD research and one of my program cells involved in the discovery and also the creation of the company that ended up getting approval to go into clinical trials. So this current product is an injectable gel, as I said, onto the drum, and it releases a growth factor, heparin-binding epidermal growth factor, like growth factor, which is a growth factor that stimulates the progenitor cells. And these are almost like stem cells of the ear bone that kind of attaches to the eardrum that then turn into skin cells that allow it to grow across as a new eardrum for the patient. The exciting thing about this is it's undergoing currently further formulation development, so we can get the formulation better before we go back into human clinical trials. So far, we were able to show that it was safe, and now we're working on improving the efficacy through a better formulation. And the last area of chronic otitis media that I wanted to talk about was CSOM, or chronic suppurative otitis media. So this is when those infections that I mentioned start becoming infected and you can't clear it. So this is a really big problem. It's the #1 cause of hearing loss in the developing world. You can see there at the top right, that sort of orange band there, it goes across the equator, and it's really common in the peri-equatorial region of the world, especially developing countries. You can see there it just catches the top of Australia, which is where I was born, raised, and trained, and I had a really big introduction to this problem. I mean, the Australian Indigenous children have an almost 50% incidence of this infection, so it's a really big problem in the Australian outback. But certainly, we've done a lot of work to understand how big a problem it is in the United States. And you can see there on the bottom right, it does affect the warmer states a little bit more than others. It does seem to affect lower demographic areas than others, but about a 10% rate in Indigenous North Americans, and a relatively high rate just in everyday Americans, and particularly this is in line with what we find in Europe or in metropolitan areas of Australia, is that there's a group of patients that just find it really difficult to shake this condition. And of course, we have a number of different treatments for this. And this is on the bottom left is a cartoon of what it looks like. And a lot of the problems with this is that we have a treatment entryway in through the eardrum, but it kind of links into your sinus behind your ear, which is called your mastoid, and you can have the areas and pockets of pus and infection everywhere that are really difficult to get to. And so we have different ways of getting there. We can try and wash out the infection. We can use antiseptics or acidifying agents to clear it, or we can use an antibiotic, which is a fluoroquinolone, which is a type of medication that we give into the ear. And sadly, we only have one approved antibiotic for use in this condition. And so we looked at our results over a long period of time, and this kind of shows you, this graph is every patient who starts with the disease, but then starts getting medical management through either washing the ear or topical antibiotics and things like that. And this shows you what happens to them over a period of time in months. And sadly, you can see that 50% of patients recur within 4 months. 75% of patients recur within 12 months. This disease has a huge recurrence rate. Over a period of about 5 years of follow-up for our group of patients. In here, we looked at 175 patients that had 5-year follow-up. That included almost 10 visits to the ENT, 5 prescriptions, and on average about 2 surgeries for patients. So this thing is just notorious for coming back, leading to multiple medical treatments and multiple surgeries. And so even with surgery, this is the outcomes if we were to operate on these patients. You can see the 50%, you can see the little dotted line, 50% of these recur at about 5 years. And if I told you that I had a surgery for your condition that recurred with 50% of the time, would you go through with it? Well, unfortunately, that's exactly what we expect our patients to go through because it's the best current standard of care at the moment. And so we almost feel like we're really fighting a tide of disease here, both with the current limitations of medicine and surgery. So one of the big things that we're doing as a lab and research group is we have a global collaboration and the biggest of its kind in the world, where we have over 150 and growing every day of clinical isolates of bacteria from patients with this condition. So across 3 universities in the United States and 3 international universities in Egypt, Iran, and Egypt. So across that, we have a really good understanding, or we're getting a real good understanding of this disease worldwide. And to dig a little bit into the science about why this doesn't get better, I wanted to introduce some concepts to everyone who's listening. So the first thing is that when you have a bacteria, it likes to, and you feed it, it likes to grow, and that you can see there on the bottom left, that's the growth curve that we plot. So first, the bacteria stay asleep. That's why they don't move much. And then when they start to eat, they grow in this exponential phase. And then once the food source starts to run out, we call it the stationary phase. That's what the growth cycle of a bacteria tends to look like. And here the example is Pseudomonas. And we term that planktonic bacteria. And what you usually see that in an infection is if you see like pus coming out of the ear, you have a wound that's exhibiting pus, or if you get septic, if you get a fever, that's usually the planktonic version of that bacteria. It's that bacteria getting hungry and swimming around and causing pus. And we typically can culture that, we can test it, we can send it off to our lab. We test that with a test called the MIC, or the minimum inhibitory concentration, where we test the different susceptibilities to different antibiotics to that patient's bug. And we get like a panel back, and it'll say like, yeah, you can use this drug or that drug to treat this infection. And that's how us as physicians treat infections. We take a swab of the infection, we send it to the lab, we get these MIC results that we then use to test us. And that really works really well for infections that are acute, that are growing, and then are producing a lot of acute pus. The second concept is the biofilm, which I think is now starting to move into lay literature. So you may or may not have heard of it, but it's getting more common. And so biofilms are communities of bacteria. They look, macroscopically, they kind of look like slime, and any surface has a biofilm, and that's sort of like, for germaphobes out there, every time you hold a door handle or things like that, there's going to be a biofilm on that door, and it's these bacteria that kind of stuck to that. But most of them, they're living in communities, and they're using these communities for survival. They are living within these communities that have a little protective matrix on the outside, and that's what's slimy. But inside, some of these bacteria are very metabolically active. They're growing, they're eating, all that sort of stuff. Others within there, they're often asleep. And that's how the biofilm survives, is that they kind of help each other as a community by providing food and resources to each other. And we currently don't test for these in clinical medicine. We know that they're there. We can take samples of biopsy of the disease. We can look up at them under the microscope, but there's no way that we really test for them. We just know that these diseases have them, or any chronic disease, any surface-mediated chronic disease really has them. And certainly we know that they're there in these conditions in otitis media. The other challenge that we're learning through our innovation here at Pitt is knowing that a lot of these bacteria within these biofilms are really the problem, and we call them persister cells. And they're not really any different other than the fact that they're sleepy, that they're sleepy because they're metabolically inactive, and they don't really have much activity going on with them. And the problem is that all of our antibiotics that we have in our cupboard or in our pharmacy, all of them that we have need a bacteria to be metabolizing to work. So they can imagine that the antibiotics that we have will work really good in that condition one, where the bacteria are growing rapidly. We can fight them with our current antibiotics. But unfortunately, if the bacteria is asleep, like they are in chronic suppurative otitis media or many chronic conditions, the antibiotics do not work because there's no ability for them to be metabolized by the bacteria. And so what happens in a condition like chronic suppurative otitis media, and this is a cartoon just showing what happens on the surface in the ear, is the antibiotic can come in, and what it does is that it can get to that biofilm, which is those little blue-gray cells down the bottom. It can kill all the bacteria that are dividing or metabolically active, but the persister cells that are not metabolically active at that point in time and are sleepy, they then just hang around. The antibiotic then goes away, you stop treating them, and then the persister cells proliferate. And what it looks like is that when a doctor treats a patient with an ear infection with antibiotics, you feel like, hey, look, it's getting better. All the discharge has gone away, the infection's, magically gone. But then it comes back weeks to months later. You get another prescription of antibiotics, it goes away, and then it comes back, weeks to months later. And often what can happen is you have these repeated cycles that just, you see the doctor, you get the antibiotic drops, it goes away and it comes back, and it goes away and comes back. And that's because you're really treating those dividing cells, but you're not treating these persister cells which remain. And then what happens, these persister cells over time, they then wake up and then they repopulate to form that infection again, and then they start discharging. And for those patients that have these chronically draining ears, we all know this cycle really, really well. And I think one of the large innovations that's coming out of our lab is that we're looking at understanding why we lose hearing loss in this condition. And so this is, a cartoon of, on the left, just showing every time we're treating with antibiotics, we're helping the battle, but we're really losing the war because we're just prolonging the condition. And this is an audiogram of one of my patients who had this condition in her left ear. So on the right ear, the hearing is normal. And what we're looking at here is, when we look at hearing tests, is the decibels goes down the vertical axis, and the frequency goes across the horizontal axis. And you can look at the right ear there in red as what normal for that patient kind of looks like. And in her left ear, what we see is the inner ear is recorded in those parentheses or those brackets, and there's a drop down to the X's, which is where her conductive hearing is. So this patient has a bit of a conductive hearing loss in the low and middle frequencies, and a very large sensory hearing loss in the high frequencies. And that's what we're finding out, is that if you don't treat or get rid of these infections in the long term, you're potentially doing permanent sensory hearing damage to your ears, which is why we're getting a lot more aggressive with treating these patients early. And sadly, you know, in this condition, in this patient, she didn't take my advice in treating it. She really wanted to just leave it be. And I saw her 5 years later, and you can see there, we're now going down. Not only are the X's dropping down to where the boxes are, so we have even more hearing loss in that ear in the conductive frequencies. But if you appreciate, though, we've gone from where the red is to the blue, and we've even had a drop in her sensory hearing. So she's developed some permanent sensory hearing loss that we'll never be able to fix in her ear. The other thing that can happen when we treat patients repeatedly with cycles of antibiotics is we can develop resistance. And what you're seeing there on the top right is the MIC, and you remember that's the lab test that we sent off for looking for sensitivity to the antibiotics. And when you've never, and in this example, when a bacteria has never seen an antibiotic, it will be totally sensitive to it, and you'll have an MIC of 0, which is what we recorded on the left. And what we've done here is we get we get the antibiotic, in this example, ciprofloxacin, which is the antibiotic drop that we typically use in otitis media. We get some Pseudomonas, and we treat that Pseudomonas with ciprofloxacin, and we treat it with really high doses. And what we do is we recover what's left after treating it with really high doses, and then we treat it again, and then wipe away all the dead bacteria, take what's left, and then treat it again. And what is actually happening is that it is the situation that I described earlier with these persister cells. So the bacteria should die if they're metabolically active, and if they're not metabolically active, they can be woken up for each cycle. And what's happening here is you can see there, if we cycle them over time, and that's the passage, is we do this, and you can see there that there's a little bump at 3 passages in the MIC, and then another little bump at 6, and then at 11. And before you know it, you can see that little pink graph skyrocketing there. And that is showing that antibiotic resistance is developing to ciprofloxacin because we're not able to kill all of the bacteria in that dish at that point in time, which really shows that over time we're really developing resistance, antibiotic resistance in the ear of our patients that we're treating repeatedly. And what that looks like if you're a patient with this condition is that and the first time you get antibiotics in your ear, it works. The second time, maybe it works. Third time, maybe it works. Fourth time, sort of works. Fifth time stops working. Before you know it, you've got this discharging ear that you can't suppress with antibiotics, and becomes a larger problem. And this is just showing you, and it's a little bit of a complex scientific slide here. But what we did is we took that bacteria that we then treated with ciprofloxacin. And remember, this bacteria is only ever treated with ciprofloxacin. But then we tested it against other antibiotics. So there we've got meropenem, imipenem, colistin, tobramycin. These are some of the most advanced antibiotics that we have that the bacteria has never seen. And what can happen is, you can see there is that the normal bacteria, which is the black, its resistance shifted to the left into the pink. And what's that showing is that these bacteria have developed resistance to other antibiotics that it's never seen. And it's because the bacteria has these mechanisms to spit out these antibiotics once it get in. These are called efflux pumps. And what it does, it develops multi-drug efflux pumps and genetic modifications to these. So unfortunately, these bacteria that we're culturing in our ears and exposing to these bacteria, so these antibiotics, and we're not killing them off, sadly, we're developing multi-drug resistance in our own ears and our own patients. And so this is a really big challenge that we need to fix. So the last innovation that I wanted to highlight is our solution to that, and it's still hopefully moving out into translation soon. And I really wanted to highlight the work of a research scientist in our lab, Dr. Bakali, who co-invented this. And he came up with the idea that we could potentially leverage the low metabolism of these bacteria. So the food source that all cells use is called ATP. It's just the name of the food source. And so whenever cells want energy, they use ATP. And we actually worked out a way to leverage this ATP as an opportunity. And we do this with a nanomedicine. And we do this, and it's actually functionalized gold nanoclusters. So we're dealing in a size that is really, really small. So the size here is 4 nanometers, and if you put them in solution, they kind of look brown there. You can see there in the tube. But if you want an idea of what that 4 nanometers actually means, where a water molecule is 0.1, a glucose molecule is 1, and an antibody is 10. So we're way smaller than a virus at 100 and way smaller at a bacteria at 1,000. So we're sitting somewhere between 1 and 10 in terms of size, so incredibly tiny. And the really exciting work results is that we can actually kill these bacteria. So this table is showing you some really exciting results. So what we did is we grew all these bacteria. In these examples on the left are Pseudomonas, Staph, E. coli, Klebsiella, and these are XDR bacteria. So what these are they're called extensively drug resistant. So these are given to us by the CDC, and these are bacteria that no antibiotics are able to kill. So these are the baddest bugs that you can find. And what we did is we grew our bacteria in biofilms, and that's what the MBEC means. The MBEC is the minimum biofilm eradication concentration. So what is the minimum concentration of the drug that is able to kill? And just for some relevance, you need to be under about 600 to be effective in this condition of otitis media. So when we use our standard of care in this example on the left column in red, ofloxacin, OFL, the amount of drug that you need to kill these biofilms is way above 600. So it actually makes sense that they don't work. In the far right column is just a control using another gold nanoparticle showing that didn't work. And in our middle column showing that all in green, the concentrations are all below 600, and that we have the potential to use our modern nanomedicine to kill multi or extensively drug resistant bacteria that could one day hopefully cure chronic suppurative otitis media. So I'm sorry to finish on some deep science, but I really wanted to show you the breadth of what we're working on here in Pittsburgh, from simple medical devices to potential therapeutics that could heal the eardrum or cure chronic infections. So we're really proud to have that whole range of focus here in Pittsburgh. And I also wanted to thank a lot of people in our lab that are working really, really hard to cure all areas of otitis media.
Wow. Boy, Dr. Sanmaria, thank you so much. It's amazing to me, how long, we've known about, of course, otitis media and the treatments with Charlie Bluestone and everybody, back in, but, really, and I'm looking at here, there hasn't been, beyond antibiotics and tubes in the ears, it seems like there hasn't been a lot of new answers or innovations. And well, one, congratulations for everything you're presenting, but why do you think that is?
Yeah, I would say there's lots of things that have impacted otitis media. I think one of the biggest things was probably in the early 2000s was some of the vaccines that came out for kids. Haemophilus influenza was a big one, and that really did drop the acute otitis media rate. And so there has been a lot of impactful things in otitis media. I think, until very recently, it hasn't been a large focus for our government or our NIH to fund. And so typically, and it's not that it's less important, but it's just been another focus for them has been looking at a lot of inner ear problems. rather than looking at what is more common to patients. And
Well,
so that was where, maybe in the last 5 years, there's been a refocus by the NIDCD, which is the institute that looks at this, as say, hold on, like 60% or 70% of our healthcare expenditure in ears is really at otitis media. So we need to start supporting this more. And so I think that's probably part of it, is that probably it's been hard to get research funding in this area. And so that opens the door. But I also think that it's a challenging problem. Like you can see there, it's so widespread and so challenging. And I think that those two things have really held it back. But I think that's why you say hopefully starting to see a lot more happen, and hopefully a lot more hope for patients with these conditions.
yeah, well, thank you. It certainly, this is inspiring everything you're doing. So thank you very much. Maybe we'll have you stop sharing and I'll get to these questions. We got a few questions
Yeah,
here. And so first
you got
is
it.
that this is often thought of as a children's problem, but adults can have this too. I think you said some people have it chronically.
Yeah.
What is kind of the oldest patients you see with otitis media?
Oh, I think I've seen people in their 90s with otitis media. I mean, it is, we do talk about when we talk about it, we talk a lot about it as a pediatric disease. And I would say it's probably, when we look at the epidemiology, it's about 50% pediatric and 50% adults. Of
Mm.
course, there's more adults than kids. That's why it is that, but so it's more prevalent. Of course, it occurs more in kids if it's more common, but across the whole spectrum, it definitely it's evenly split between adults and kids. Um, but it really the problem with otitis media is it's a spectrum and it catches you right for a long time. So you have the typical story is you have these children that are getting recurrent ear infections. They get these tubes. The tubes fall out. They get multiple tubes. They then present as teenagers and they're getting chronic suppurative otitis media, or now they're getting cholesteatoma, and then we'll operate on them, and then we'll see them 5 or 10 years later, and they get another surgery, and then it's just like a mountain of problems that persist through adulthood. And I think that's the issue with this, is that it's not like a one and done infection. Like it's something that just persists and comes back and presents in so many different ways. So certainly even though I do see children, my practice is predominantly adults, and that's the burden that I usually take care of.
Well, and sadly, as you said, throughout the time that they're dealing with these infections, it's very hard for language to develop, and imagine again trying to hear your teacher when you're dealing with essentially closed hearing systems. So
Yep.
so you must got people thinking about popping their ears as you've been talking. So is forcibly popping your ears, like holding your nose and blowing, dangerous and harmful? Can you hurt yourself doing that?
There are people that have hurt themselves with that, but the majority of people don't. So I think the thing to realize is that if we talk about pressure, PSI, and what we're talking about here is a Valsalva maneuver,
Hmm.
and that can get up in the range of 5 to 10 or more PSI. So a normal swallow, when you open up, can open usually like zero point 0.5 to 1 psi. So we're sort of like 5 to 10 times that. So I have seen people that have caused like perforation of the drum, especially if it's a little weakened, if it's infected, by doing the Valsalva. I've also seen people that are habitual people popping their ears that can develop floppy eardrums from that, because they're
Oh,
just popping out and ballooning out or weakening the eardrum in that
oh,
point of view. So you can, but I think there's usually like if you're doing it gently, it's probably okay. If you're doing it forcefully, it's probably not okay. So you just got to be careful. What I usually teach as an interim to that is it's called the Toynbee maneuver. It's Joseph Toynbee is an old otolaryngologist from a few hundred years ago. But you would hold your nose and swallow, and that is a
ah,
much gentler opening than holding your nose and blowing. And
okay.
so that's kind of sort of an intermediate step.
Oh, that's a great tip for everybody out there. So, do you envision earflow as something that will be sold on a retail basis or only available with physicians? I saw you said it's going to be, you think, available in this winter. That's exciting.
Yeah. Yeah.
So, how will it be retailed?
Yeah, so first is the disclosure that I am a founder in founder and inventor in Airflow.
Okay, yeah.
So I want people to know that. The second thing is that it's going to be sold through commercial channels through the website. There's going to be discussions with some online retailers and things like that. So it won't be sold through do doctors. It'll be direct to consumer. So hopefully recommended by doctors, but available for patients to get themselves. What I also I think there's a lot of light bulbs going off and people probably looking at you. Yes, you can use it if you're an adult.
Mhm.
And there is different masks that can be used. We really did a lot of the development in children because that was the primary area of need, was to avoid tube surgery, but adults certainly can use it. Anecdotally, I know a lot of people that borrow it from me all the time to use it.
Yeah.
And we're actually excited to be doing some adult clinical studies here in Pittsburgh soon. We're currently just going through the trial approvals here at Pitt to get that ready. So there will be at Pitt the available to be sorry, there will be at Pitt the availability to use it in the clinical trial setting or the potential to get it via the consumer market later this year.
Well, and I do know your excitement about it, not as it relates to even the U.S., but also around the world. Uh, and so this is really my question, but I know that the in the developing world, this is a much more significant problem. So that, because you don't have antibiotics and enough ENTs to be able to do the surgery for the tube. So do you envision that your flow would be an answer for things for people in regions around the world or even around the US where care is less accessible?
Yeah, absolutely. And I think the highlight there is that care is less accessible. And I think we could argue in metropolitan US, care is not accessible for most people. Like it's really hard to get to an ENT doctor. And
Yes.
so it's just hard. And like to take that a little bit further, a lot of the development for earflow had been done in Western Australia, which is my where I was born. And we did a lot of development there because it was happening during COVID, and Western Australia was this little bubble where there was no COVID. And interestingly, it's a 2-year wait to see an ENT doctor in Western Australia. And so, you have these kids that would have this hearing loss that would then wait 2 years, and by the time you've already got speech delay, you've already got all these problems, and it's a nightmare. And so we had governments and everything desperately trying to find solutions in there. So, it's I think care is inaccessible, even in like the city of Pittsburgh or wherever. It's
Yeah.
like it's hard to get to an ENT. But no, what you're looking at is like, we've done a lot of work in rural areas, particularly we have a focus in Mozambique. We're going there in a couple of weeks to help further this along. Mozambique is a country of 30 something million, of which there is 13 ENTs.
Yeah.
And of course, those people aren't seeing those 13 ENTs. So we're going to we've launched that in an area where in fact there's not even any doctors. So how do you treat this problem when you don't have doctors to do that? So along with some collaborators, we're able to bring some machines that were to allow the healthcare workers to test for this potential problem and actually use this device to treat the problem without even seeing a doctor. And the harm of using this device is relatively low. And so we're actually seeing the ability to potentially even bypass the wait to see physicians in using this. So I think hopefully it'll have a really big impact in all areas where it's difficult to access physicians.
Excellent. All right. Are there environmental factors which lead to more frequent ear infections? You mentioned that it's more prevalent in the north than in the south.
Yeah, absolutely. So there's a huge amount of epidemiology that sets you up for otitis media. And these are really, really well studied. So being unvaccinated,
Yeah.
not being breastfed is a big thing. Being in an environment where there's smoking
Mm.
or allergens. I know a lot of people around Pittsburgh greater area are subject to allergy. Living conditions and sort of things that promote, and with because the ear is like you get ear infections from upper respiratory infections, you can imagine like all those sort of conditions that promote bad airway health can also promote poor ear health. And so there's a lot of environmental areas. So The chronic suppurative otitis media, interestingly, that's why with the warmer areas, there's a lot of communities that swim a lot or swim in outdoors. Swimming in lakes or dirty water can promote those sort of infections. So those things are on the chronic suppurative otitis media side as well.
Very interesting. So, can infections of the ear move to other parts of the body and cause other issues that are difficult to resolve?
Yeah, this is entering like what we know and what we postulate. So the scary thing is when you have an infection of the ear, you can measure bacterial markers in the blood, and that's even without being sick. So, we're often, familiar with like really bad throat infections or really bad bladder infections. You can have a fever and all that sort of stuff. That's usually the symptom of something getting in the blood and a bacteria, a body fighting that. But even when you don't get a fever with most of these chronic ear infections, we can detect things in the blood. So certainly, not necessarily like the frank infections, but there's a lot of research going into whether or not there's effects long term in the brain from having these seeded infections going around, whether it can foster the development of neurodegenerative diseases, long term effects like that. I think I'm not trying to scare everyone, but those sort of
Yeah,
things are
well,
areas of ongoing research.
well, I think it's a good message to tell everybody that it's important to address it. Like you shouldn't let
Yeah,
your kid go on with untreated, ear infections, obviously.
yeah.
So, okay, so can parents do anything to preventative to lessen the children's chance of developing ear infections? That's the question.
Yeah, I mean, yeah, that is a good question. I think all those factors that we mentioned before, the opposite. So, vaccinating children, diet and lifestyle, making them healthy, trying to reduce exposure to smoking. The breastfeeding actually is a known factor. So, breastfeeding your kids, like all the things that we
Mhm.
do to try
Yeah.
and make kids healthy. And I think regular checkups with physicians and avoiding allergens and all that sort of stuff, but all those sort of things that we generally try to do with children anyway are really important. I think once you have those ear infections, what are things that we can potentially do to prevent having ongoing things? I think yeah, those sort of things are areas that we're trying to look into research. Is there like you know people have joked about, should we be doing earwax transplants and all those sort of things? Like, I don't know. That's other areas of research that we're still
Interesting.
looking into.
Interesting. All right. So, what are the ear drops that are prescribed for children instead of antibiotics? That was a, is there something else?
Yeah, I mean, there's things that there's antibiotics and I guess antiseptics or agents that cause the pH to go down, so acidifying we call it. And I think those sort of things are most of them can be toxic. So I think that's the that we need to promote. So just got to be a little bit careful. So when the eardrum is closed, so like if you have like swimmer's ear, you have like an outer ear infection, it's relatively safe to pour these other things in there, like
Okay.
peroxide or alcohol or vinegar or these other things that we can pour in there. When the eardrum is open, that's when you have to be really careful, and that's where we say, look, just got to be under the advice of a physician. It's going to be done really carefully because a lot of these can actually cause inner ear damage if not done correctly. So that's kind of the group of things: antibiotics, antiseptics, and things that lower the pH of the thing to help suppress the infection.
Okay, great. Well, we've all taken flights where there's a poor young child who is just miserable because of the ascending and descending. So the question here, what can be done to help children endure the pressure of the air on the ears when ascending and descending in an airplane?
Yeah, so the issue there is that often the children's eustachian tube doesn't fully develop till around the age of 7, and so that's why children below the age have these problems. It's a secondary to the eustachian tube issues, and so when you're going up and down on the flight, you have these extreme pressurizations or really rapid transitions that the children's eustachian tubes can't handle. So the first thing is, and everyone's heard about earflow as a potential solution. So that is definitely something in the future. But I think talking about some other simpler things that can be done now is just encouraging the child to swallow. And so for very young babies, you'll see mothers trying to breastfeed as you're ascending or descending. Having that child swallowing repeatedly is going to be the biggest trigger. But if you're not breastfeeding, drinking from a bottle, or drinking and chewing, actions can pull on the eustachian tube muscle to get them opening. And then secondarily, if that's not quite working, try to encourage a child to hold your nose and swallow during the Toynbee. Sometimes when you've reached that point when it's really painful, doing the Valsalva can actually hurt even more. So we try to advise against that.
Yeah. Well, not only was this interesting, informative, giving us hope for the future, and think in terms of some really good solutions for people. You also gave a lot of nice tips and things to take home to families. So thank you. This is a great webinar, and I appreciate your participating with us today, and all of you that have joined us today. Thank you. And you'll receive a video copy of this in a few days. Feel free to share it with your friends and all your people with children. And we look forward to seeing everybody in the next couple weeks for our next webinar series. And everybody, please have a good day. Have a safe day and a great weekend.